Payment Models webinar presented by the Visiting Nurse Associations of America. I'd like to turn it over to Corey Rutledge with CliftonLarsonAllen to introduce today's program. Corey?
Good afternoon, everybody. Thank you for joining us this afternoon. Many of you heard from me approximately a week ago on the 27th of February when we introduced the relationship with VNAA and CLA. And during that time, we mentioned three themes that we're focusing on this year in terms of the education sessions that we're going to be providing to VNAA and its members. And those themes are, one, optimizing performance in today's fee-for-service environment, two, communicating your value proposition, and three, achieving success in alternative payment models. And today's education session really focuses around that third and final area that I mentioned, and that's achieving success in alternative payment models. And really, as I think about today's conversation, it's about setting the stage and getting everybody a base knowledge on alternative payment models so that in future education sessions, we can dig deeper and really get into the nuts and bolts of different alternative payment models and how they can impact your organization. As we think about the ultimate goal of this VNAA and CLA relationship, it's really about increasing the financial aptitude of your members so that you can better interact and achieve better financial results as you engage in this industry. So I'm pleased to introduce Deb Freeland. Deb is out of our Indianapolis, Indiana office, and her role within CLA is really leading our payment advisory work within our post-acute world. Deb has a number of years of experience in helping organizations from a reimbursement and payment advisory standpoint, helping them navigate both traditional fee-for-service payment as well as alternative payment models. She's very well educated in terms of the movement of health reform and has spoken both locally and nationally on this topic in a variety of areas. So please join me in welcoming Deb. Deb, thank you for your insight, and we look forward to hearing what you have to say today.
Great. Thanks, Corey. Good afternoon, everyone. So as Corey mentioned, I really want to focus our time today on just an introduction to alternative payment models and what that looks like in the home health space, just to give you guys an understanding of where payment reform is going in the post-acute care world. And technology is not my friend today. So just going through the agenda to give you an idea of what we want to talk about today, just looking at some of the environmental factors, some of the new payer contracts, what a preferred provider relationship looks like, talking about the value-based payment programs and the outcomes of these programs, what we've seen already to date, and what some of the payers are looking for out of a value-based payment program, looking at bundled payments and accountable care organizations and what role your organization can play in some of these alternative payment models. And as Corey touched on also with some of the other sessions, looking at some of those key quality and performance metrics and why they're really crucial to understand those metrics and be able to provide those metrics under these alternative payment models. And then talk about some of the themes and trends that we see coming related to payment reform. So when we take a look at where we're really at from an environmental perspective, this really has been the last couple of years an opportunity for a lot of change. We've seen change in payment reform with the Affordable Care Act and how that has impacted providers and how they get paid. What's really that theme of, or the goal of better care, better health at a lower cost, and really trying to tie the dollars that are being paid out for healthcare to a provider's value. So really focusing on that cost plus quality performance. And when we see what's happening in the marketplace, of course we all know the direction that Medicare is going, and we'll talk a lot about that today. But when we look at even the private payers, such as the insurance companies, they are also moving towards these value-based type contracts and really trying to get focused on that moving forward into 2020. And then we'll talk a little bit about site-neutral payments as well, which I think is going to be really important in the home health space, and provide a lot of opportunity as MedPAC talks to CMS and Congress about what site-neutral payments really mean and how we can provide better care for people at a lower cost setting. So when I talk about the transition in the payment world and all of this payment reform, you know, we're so focused and have been used to for many, many years on fee-for-service, whether it's a per-episode payment, per diem type payments. All of our payers have paid based on the fee-for-service. And as we start to move down this payment reform and risk-based payment structure, we move from that fee-for-service to a value-based reimbursement system, and then we move from there to a potential bundle payment where you're negotiating on an episode price to really a total population-based risk model that, from a provider's perspective, is an all-in risk-sharing opportunity. And as you kind of take that step up in each one of these different risk-based payment structures, there's significant changes that have to take place at your organization. You have to look at new metrics. You have to look at how you're delivering care, how you're tracking and reporting information. And so the quicker we move through these changes, the more difficult it is for organizations to really stay focused, one, on performing the business that you're doing today, but how do you change and change rapidly with all of these different payment models to stay relevant as you move forward into tomorrow and the next couple of months and years down the road. So when we're looking and talking with post-acute care providers, what we really want to focus on is what do you need to do to be successful under these new payment models? A couple different things that you really need to look at, and it's really trying to think about how you do things differently. So there's this author, Clayton Christensen, who has authored The Innovator's Dilemma, which is a really good book if you haven't read it yet. But it's really talking about doing things differently and disrupting how you've normally operated your business. What do you need to do to think differently and think outside the box? And when we think about what's happening in the healthcare reform around the payment structure, around the quality of providing that optimal care for people, there's just a lot of companies getting in that you wouldn't consider healthcare providers in the past, but they might be technology companies, and they're coming in and helping you provide that care. And so you want to be able, as an organization, to really figure out what it is that you do well, defining your value proposition, and how are you going to support that with your data. What are your quality and performance metrics, and how are you going to communicate that to other organizations that you may want to partner with, or even with the different payers, and how you can structure different payment models with them? What do you look like compared to your competition? I think as organizations, we do a really good job of understanding our own organization, but we don't necessarily always compare ourselves to our competition. And I think under these new payment models and the requirement to collaborate with some of the other provider types, you need to be able to explain why your organization is better than your competition down the street. So that's going to be really important. And then, of course, understanding your cost at a patient or a diagnosis level so that you can figure out what's going to be your best approach in your strategic plan moving forward. So when we talk about the cost in the healthcare space, we always look at it from a payer's perspective. So when we're talking about the cost, we're talking about that cost of care for Medicare, Medicaid, the insurance companies, and they're talking about that total cost of care is too high, and how do we drive that cost down? So when we look at it from your perspective as a provider in that delivery system, that cost is really your revenue. And so I guess the question is what these payers are saying is that you as providers have too much revenue. Now, we all know that that's really not the case, but that's how they're looking at it. You're the cost to their system. And so we have to figure out how do we make sure that we're driving your revenue appropriately for the service that is being delivered. So I look at the new payment models and some of the keys to making these payment models successful. It really is, as I said earlier, about better performance is going to equal better payment. When we're looking at bundled payments, for example, it's about fewer readmissions to the hospital, lower lengths of stay, whether that's in the acute care setting at the hospital or in a post-acute care, or can they go to the home environment? How do we get them to that functionality that they need to be at under that bundled payment at a lower cost? Under an ACO arrangement, there's certain quality benchmarks that you need to be able to achieve before you share in any of those savings. So again, how are you going to meet those benchmarks? What are those benchmarks? Is it reasonable for you to be able to change your care delivery model to meet those benchmarks to actually share in some of the savings from the ACO? And then the third model is really the value-based payment program, where dollars are being withheld from providers and then they're given back to and rewarding those high performers or those providers that are able to improve their quality and the care outcomes. And so really figuring out how does your organization fit into any of these payment models and what do you need to do to get a better payment under each of these. So some of the themes and the trends that we saw in 2016, one is obviously the shift to a value-based payment. And we've seen this both in the private and the public sector. Hospitals, physicians, skilled nursing facilities, home health, across the board, and we'll talk a little bit about what Medicare's value-based payment programs are. But CMS is definitely using those, and they're using them in the Medicare Advantage plans as well, and really trying to influence beneficiary enrollment in certain plans based off the quality measures and the scores that each of these Medicare Advantage plans have. Also, we're seeing in 2016 and moving forward is CMS is really moving towards some of these alternative payment models, and you can see that from their shift from the voluntary payment models to more of the mandatory payment models. Now, all of this is somewhat caveated with the new administration and with Tom Price being in as secretary and really what's going to happen to some of those mandatory payment models. But as of today, they are still in place, and it was definitely a trend that CMS was moving towards, and understanding the importance of having more providers participating in these different payment models. We're definitely seeing a shift from the fee-for-service towards capitation. CMS really wants to move that direction. And in trying to do that, we're seeing that they're waiving some of what used to be the existing criteria for referrals, whether that's a 3-star rating or some other quality metrics, where hospitals may have been limited on who and when they could refer patients. Under some of these alternative payment models, there are waivers around some of those referral limitations. In the post-acute care space in 2016, we really saw a lot of interest in pursuing partnerships, collaborations, really working together, whether that's skilled nursing facilities and home health agencies working together, working together with a hospital, working with a physician group, and really trying to focus on how they can best provide the care necessary for individuals, and really being able to negotiate through some of these different areas, and really understanding their data and how they're going to go ahead and communicate that information going forward. So getting into the different payment models a little bit more in detail, I first want to start with talking about the Medicare value-based payment models a little bit. And we think about where Medicare has wanted to go and what their goals have been. It was CMS's goal to have 30% of the Medicare fee-for-service dollars under some alternative payment models, such as a shared savings or bundled payment or ACO model, by 2018. And they really pushed that and actually were able to achieve that in 2016. So that you clearly see from the administration that they were wanting to move forward with that. You know, some of their other goals was to have 85% of all Medicare dollars tied to some sort of quality or value-based payment models, with 90% of all Medicare fee-for-service dollars tied to quality by 2018, with 50% of those in some sort of alternative payment model. So we look at the impact of these alternative payment models on Medicare beneficiaries. If you look at the population, and everybody talks about the baby boomers and how many more people are going to be coming onto the Medicare rolls and what that projection looks like, in 2015, we had about 54.7 million Medicare beneficiaries. And that's projected to grow to 80 million by 2030. So if you think about just the fee-for-service world, in 2015, we had 69% of that 54 million, or about 37 million, that were in fee-for-service. And so we started to see that shift in 2016, where a lot of those fee-for-service members were now starting to go into ACOs. So we saw just under 9 million of those Medicare beneficiaries going into ACOs. And then we started seeing some of the bundled payments with the lower extremities, the comprehensive joint for knee replacement bundle, and then we're seeing a lot of the Medicare beneficiaries going into an Advantage plan. So as we project out that 54.7 million to 80 million, it's going to be really imperative for the Medicare program to be able to have these individuals in some sort of alternative payment model. So when we look at the value-based payment models and what CMS is moving towards, and they've really, as you can see, they've hit all of the different provider types: hospitals, physicians, skilled nursing facilities, and they've even done this in the home health space, where in 9 different states, they've incorporated an incentive payment where the payment has been tied to quality performance in these different states. In the states were Massachusetts, Maryland, North Carolina, Florida, Washington, Arizona, Iowa, Nebraska, and Tennessee. And it started in January of 2016, with the payment adjustments are starting in fiscal year 2018. And when we say implemented, that's when they're starting to measure the different quality payment, or the quality measures. And then those quality data points are what is going to be used to adjust the payments starting in fiscal year 2018. So the measures that you're currently reporting in OASIS, if you happen to be in one of these states, that information that's going into OASIS and the claims data is what is going to be used to determine whether or not you get a payment adjustment of anywhere from 3 to 8%, and it can go up or down sometime starting in 2018 through 2022. And so it's really important that as an organization that you understand that the information you're submitting now is going to impact your payments in the future. One of the other things under a payment reform, and we've all heard about the IMPACT Act by this point, but MedPAC has really said, and this was part of, came out of the Affordable Care Act, but really focusing on standardizing patient assessment metrics across all post-acute care providers. And so what CMS is saying, and MedPAC is gathering some of this data for them, is really trying to standardize and looking at the individual and what the needs are of the individual, and how does Medicare pay for that individual service that they need and the care that they need, regardless of the site of service. It really is focused on the individual and not where the services are being provided. So definitely looking at a site-neutral payment. And MedPAC even came out last week with an update to that, where they're really trying to push CMS into implementing some of these site-neutral payments much earlier than originally had planned. So they really want to start rolling this out in the next couple of years and making it a 3-year transition where you're starting out with still having your payments at the site of service, but by year 3, which would be in 2020, that all payments would be site-neutral payments. So clearly there is a move by MedPAC to get Congress to move much quicker on this than they had originally planned. So I won't go through all the dates on this, but when we look at the quality reporting timelines under the IMPACT Act, everybody should have started some of their quality reporting measures that will be used in determining those site-neutral payments. So for home health agencies, you're started in January of this year looking at the skin integrity and changes and Medicaid reconciliation. So again, those payments, the focus is really to look at the individual patient characteristics and not the site of service. When we look at the IMPACT Act, some of those quality reporting measures that are starting to be used, and I touched on some of those a little bit, but just looking at the specific domains that are being measured starting this year, looking at the skin integrity, functional status and cognitive function of the individuals that you're serving, the medication reconciliation from one provider to the next, incidence of major falls, and the all-condition risk-adjusted, potentially preventable hospital readmission rates. So the ultimate goal in looking at all of these is really to facilitate care coordination and the seamless handoff of an individual from one care setting to the other, and making sure that we're really focusing on that as they move, whether it's from a hospital setting to home and using home health services, or if it's from a skilled nursing facility, and making sure that there's good care transitions as they go through that process. So switching from value-based payments to one of the other alternative payment models, which is the Medicare bundle payment, there's really 2 bundle payments out there at the moment. There's the bundle payment for care improvement, which started back in 2012. And this is a voluntary bundle payment arrangement at this point. There's about 1,600 different participating providers. And the way the bundle payment works is you can pick from certain episodes or DRGs out of 48 possible. And whoever you're working with, whether you're working as a standalone home health agency or you're partnering with a hospital, as a group you decide what your discount is going to be that you're going to agree to take from Medicare. And you can make it either a 30, 60, or 90-day episode, depending on which model you choose. And you're going to provide that care for that bundled payment. So everybody who has agreed to participate in that bundled payment is going to take that reduced payment, and everybody needs to focus on providing that care at a lower cost. So again, like I said, this is voluntary, and then CMS started moving towards the mandatory bundled payment arrangements in 2016, and the first one was the Comprehensive Care for Joint Replacement. And this is focused on primarily the 800 hospitals in 67 metropolitan statistical areas or urban areas, and really focusing on those lower extremities and joints. This one does not have as much flexibility as the voluntary bundle payment for care improvements, and where you can't decide on your discount and you cannot decide on the length of episode. These are 2% discounts and a 90-day episode. So again, if you happen to be in one of those 67 areas, you may be working with hospitals and figuring out how to lower the cost of care for those individuals going through a comprehensive or through a joint replacement program. Now, there was a second mandatory bundle payment that came out, the cardiac bundle, that was supposed to start this year, but with the change in the administration, it's still out there, but from my understanding, it hasn't started just yet. So I look at the bundle payment for care improvement. When we talk about home health agencies, Model 2 and Model 3 are the 2 models that home health agencies can participate in. And when we look at these, if you look at who's participating, as of the end of 2015, there's about 1,600 participants. 109 of those were home health agencies that were either the awardees where they started out doing, they initiated the Model 3 bundle payment program. And so when we look at these, Model 2 always starts with an acute care stay at the hospital, and the hospital is part of the bundle. And then it includes the post-acute care. And then Model 3, they still have to have an acute care stay, but the hospital is not part of the bundle. It is just the post-acute care providers only in that bundle. So we do see quite a few post-acute care providers who have said they want to be able to manage the process a little better, and have gone ahead and participated in a Model 3 without the hospital being part of that bundle payment arrangement. When we look at whether or not it makes sense for you to be in a bundle payment arrangement, when you look at what are the drivers, the financial drivers of being in a bundle payment arrangement, you know, a couple things that you want to keep in mind. If you look on the upper left of this slide in the black section, this is a sample home health agency that we worked with just to see what it would really cost them and what were the financial benefits for them to be in a bundle payment arrangement. And so when we look in the upper left in the black section, so they started out with 3,812 bundled payments as their baseline. And these were 60-day episodes, and they had agreed with CMS to take a 3% discount on their bundled payments. So to be successful in a bundled payment arrangement, it's not just about taking the discount. Because if you think about it, if all you're doing is taking a discount, you're saying you can provide the same care or better care at a lower cost than you've already been doing it. And in most cases, most providers are already doing the work in the most efficient way possible. So really, how are you going to really obtain the 3% discount? Part of that is being able to change some of the costs within the bundle payment. So if you go to the green section for this provider, their goal was to reduce readmissions to the hospital by 25%. And so that would then reduce the overall cost of care for that particular bundle. And then as you go to the blue section, they also wanted to make sure that if they're getting in this bundle payment arrangement, that they actually are benefiting and growing the volume of people that are in the bundle. So they were able to increase their market share by 35%, or 2,188 episodes within their bundle. And then by leveraging that bundle opportunity and some efficiencies, just with the scale, they knew that they could reduce their overall cost by 49% compared to what other providers, whether it was skilled nursing facilities or other home health agencies, LTACs, that they could do it for less expensive than other providers. So when you look at the bottom at the key financial results and what the impact of this particular home health agency being in the bundle payment is, when you look at the first line, the bundle gain share, because they were in the bundle and they were able to increase their market share, they actually increased their revenue by $3.2 million. And then with some of the other impacts of being in the bundle payment, they had additional revenue of $7 million. And when you go to the variable expense line, obviously if you're treating more people, you've got more staffing expense, there's more operational expense, things that go into, there's an administrative cost for being in a bundle. So overall, this organization saw a $6 million increase in their bottom line. So if you go over to the right side and you look at overall what the benefit was, both to the home health and to Medicare. Because if you go back to one of my original slides and we talk about cost to the program, so when you talk about cost to the program, that's what Medicare is paying. So they're getting a 3% discount. So in this case, Medicare was able to save $10 million. So they were very happy with this bundle payment arrangement. And in the end, the home health agency was actually able to make an additional $6.1 million as well. So it's really understanding all of the key drivers in that financial arrangement to making sure that it makes sense. So when I look at some of the opportunities when you're talking about a bundled payment arrangement, especially when we start talking about some of the mandatory ones like the comprehensive joint replacement program, we looked at a particular market, and we looked at a 60-day episode under a bundled payment arrangement with 10,000 admissions into that bundled payment. So if you're a hospital and you're looking at this, this is where a hospital would typically send their joint replacement patients when they're discharged from the hospital. 52% were going to skilled, 38% to home health, and then inpatient rehab and the long-term acute care hospitals. So what the hospitals are looking at being in this bundled payment arrangement is, well, what if we reduce the discharges to the inpatient rehab facilities and the long-term care acute care hospitals, and we really target increasing the home health for 55 or 65% of those discharges to help us reduce costs within the bundle. So what happens is, instead of all of those individuals kind of being spread out around among the 4 different post-acute care providers, if you look at the home health line, they went from 3,812 episodes to 6,000 episodes. So a 57% increase in the home health space. And the providers under this methodology, or Medicare, was able to reduce their revenue that they were paying out, or their costs, from $183 million to $54 million. So a 16% reduction in cost to the Medicare program by just how those discharges were referred to home health instead of the institutional type providers. So I've covered kind of the detail of the comprehensive joint replacement bundle a little bit, but the biggest goal of that, if you look at knee replacements, is there's a lot of variation in cost and the quality of care for those hip and knee replacements across the country. Some of it is geographic, but you can have a lot of variation even within a certain geographic area. So CMS is really looking at taking the information that they gather out of the comprehensive joint replacement bundle and setting prices based off performance over the next 5 years. And then really, as part of the bundle payment, there's a reconciliation at the end of each bundle that's going to be based off your fee for service that you're paid in the bundle, and what some of your quality and your outcomes are in that bundle payment arrangement. So I look at the key elements of the comprehensive joint replacement bundle. Like I said, it started in April of 2016. The bundle does include all Medicare A and B services related to those joint replacements, and the hospitals are only eligible to receive savings if they meet certain quality metrics. So under those knee replacements, the patients are to reach a certain functionality level before they're discharged to home or discharged from the bundle payment arrangement. And so the hospitals need to be able to document that in working with all of the post-acute care providers that they're working with. And then the hospitals are allowed to share in some of those savings with the other collaborating providers, whether it's home health agencies or other post-acute care providers. So from a hospital perspective, again, they're trying to manage the total cost of the bundle. And so they've agreed to a certain price, and everybody within the bundle still receives fee for service, and then there is a reconciliation at the end. And then the hospitals can receive a quality incentive payment along with that. So if the hospital exceeds their bundle target price, they need to repay a portion of that. And then if they're below their bundle target price, then they get to keep those savings and they can share some of that with the other providers. So we've kind of covered all of that as far as the reconciliation. The process of sharing in the repayment for the comprehensive joint replacement, in year 1, if they did exceed their target price, they don't have to repay any of that overage. But as you can see in years 2, 3, and 4, they do have to start repaying some of that. There is a stop loss or a maximum amount that they have to repay, but that goes up every year. And the hospitals, are aware of that, so they're doing their best to manage that cost. So this is just a good example of what a hospital is looking at from a bundled payment perspective and how to control costs. So if you look at the comprehensive joint replacement, in most cases in this particular geographic area, the cost of doing that knee replacement is just under $24,000. Now, the providers have to take that mandatory 2% reduction, so the hospital is looking at $23,000 as their target price for doing that knee replacement. And when you look at what the hospital actually gets paid under that, they get the $14,500 based off the DRG. And so they're looking at saying, okay, once we release this person from the hospital, we have about $8,696 left for that person to get care after they leave the hospital to get them back to that functionality. So historically, those individuals would go to a skilled nursing facility or an inpatient rehab facility. And when you look at the skilled nursing facility rates at $550 a day, that only provides 16 days of post-acute care in a skilled nursing facility with no home health or any other care involved in that. So hospitals are really looking at that saying, okay, well, can we send them home and get home care and therapy at home? What are the things that we can do different and bypass the skilled nursing facility altogether? So this is how all of the financial metrics are really starting to play out in some of these alternative payment models. So what does this mean for you as a post-acute care provider? Obviously, shorter lengths of stay. We're going to see that at both the hospital level, the acute care, but also in the post-acute care space. Definitely controlling readmissions, keeping the cost of those readmissions down. So hospitals are looking at those post-acute care providers that have the best ability in which to control readmissions. There are some waivers on the 3-day stay if they're discharging to a skilled nursing facility, but we're also seeing the hospitals really wanting to discharge directly to home with home health services and therapy services at home. So definitely starting to see a shift in those lengths of stay and where people are getting discharged to. And finally, the third different alternative payment model that we're really seeing CMS focused on is the accountable care organizations, which is a little different from the bundle payments, where the bundle payments are focused on specific episodes of care or DRGs. The ACOs, or the accountable care organizations, are really focused on a population of individuals within the Medicare program and really focusing on kind of that population care, the total cost of care, working together, making that a patient-centered home for them in effect. And so there's a couple different Medicare ACO programs. You've got the shared savings program, and there was about 100 new Medicare shared savings programs in 2016. There's about 7.7 million beneficiaries in Medicare shared savings programs. And when we talk about moving forward with these shared savings programs, quite a few of them are now in track 2 or 3, which means they're taking on greater risk, where they're sharing in both the savings and the risk and having to repay money if they're not meeting certain quality metrics. And then we have the Pioneer ACOs and the next gen or the next generation ACOs that have started as well. So when I look at the Medicare Shared Savings Program, like I said, there's 7.7 million beneficiaries that are participating in 430 some different shared saving program ACOs. And the challenge with these original ACOs, whether it's the Pioneer ACOs or the shared savings programs, is really the ability for them to continue to show improvement year after year. There's certain benchmarks that they need, quality benchmarks they need to achieve, And as they go through that program and those quality benchmarks, they meet them year one, then those benchmarks get raised for year two. It just becomes a challenge for them to continue to be successful at those. But we are starting to see more and more individuals go into these different ACOs and being cared for through the ACOs. And we're seeing where Medicare is really looking at them, and we talk about the next generation of ACO models. The purpose and some of the changes for the next Gen ACO models was really to address some of those metrics that are being required under ACOs and allowing them to be more financially sustainable for the long term and not just meeting the short-term quality metrics.
Get it today. I need to pull the place.
So when we look at the history of success under some of the ACOs, they are definitely getting better over time. So when you look at 2014, 37% of the ACOs were actually sharing in savings, and that's up from 19% in 2012. So when we look back at 2014, there's a total net program savings of $411 million for the Medicare program. And like I said, the Next Gen ACO program was started in 2016, and there were 18 participants in the new model. There were originally 21, and 3 dropped out of the program before they even got started in 16, where they just really figured out that they didn't have their own financial house in order to be able to effectively manage themselves under the ACO program. But part of the changes in the Next Gen ACO was to really focus on beneficiary choice and giving some benefits to the beneficiaries for choosing providers that are participating in the ACO. So again, it's kind of driving that patient choice a little bit, but making sure that the beneficiaries understood the overall benefits of being in an ACO. Again, looking at the prospective financial benchmarks, making sure that the quality is attainable and that they can continue to move on that on a go-forward basis. The biggest thing is really aligning the beneficiary minimum. Some of the problems that the rural ACOs had when they first started out in either the Medicare Shared Savings Programs or the Pioneer ACOs is you had to have 10,000 individuals within your ACO to be able to participate. And that was really difficult for some of the rural providers. So the Next Gen ACO program actually lowers that to 7,500 to allow some of the rural ACOs to be able to participate. So again, looking at this, the shared risk and full performance, there's 2 different tracks the provider can pick under the Next Gen ACOs. They can take Path A, which they're still sharing in some of that risk with Medicare, or they can go all in and take on 100% of the risk in Path B from the get-go if they chose to do so. And the discount that gets applied to their Medicare payments is anywhere from 0.5 to 4.5%, depending on their quality metrics. And again, that's tying the value back to the payments. If their quality metrics are really high, then they take a lower or a smaller discount. So they're having to give up less money because their quality is higher. So there's really 4 different payment mechanisms or payment models under the Next Gen ACO. One is the normal fee-for-service payments, and then there's a reconciliation at the end based off quality. There's the normal fee-for-service with a monthly per beneficiary per month payment, which is up to $6. And again, that's for the ACO to really do the case management and be that patient-centered home for that individual. There's population health, population-based payments, which again, there's a per beneficiary per month. The providers within the ACO are still paid by CMS at the fee-for-service at discounted rates, but then the ACO can get additional payments, and depending on you as a provider, if you're contracted with the ACO, you may be able to receive some of those additional payments from the ACO. And then the full capitation is where CMS gives the full per beneficiary, per member, per month amount to the ACO, and then the ACO themselves actually pays all the providers. So the providers are no longer paid by CMS for providing those services. So one of the ways that you as an organization can become involved in the next Gen ACO is really working with hospitals that may be interested in that and becoming a preferred provider, where you actually have a written agreement between your organization and the ACO. Allows you to get some of the benefit enhancements, some of those financial rewards for being part of the ACO, allows you to expand some of the services like telehealth services. There's some post-discharge home visits that are being allowed, physician visits under that program. But as a preferred provider, your alignments or those beneficiaries that come to you and your quality reporting is not part of the ACO quality reporting. So when the ACO is looking at that, they know that what's happening at your organization from a quality perspective is not going to impact their quality metrics. So a preferred provider agreement is a good way to go for organizations like yours. So I just wanted to quickly go through a case study where we had worked with a couple senior living organizations, 2 CCRCs and a home health agency. And these 3 organizations really wanted to work together to form a post-acute care network. And the idea behind it is that they felt if they worked together and had their own post-acute care network, they had more to offer the ACOs and the hospital and health system, or even the payers themselves, when they went to the bargaining table and we're talking about contracts and collaboration and what does this look like. And as this post-acute care network, they became a single entry point for those services to be provided. Instead of competing against each other, they were all going to work together and really benefit from all of that. And they were really looking to maximize the total cost of care payments that they're going to get under these payment models, whether it's bundle payment, managed Medicaid, ACOs, really looking at being able to share in those savings. So as they went through this process, it was not an overnight decision, nor was it successful overnight. It really took a lot of time and effort on their part to get this post-acute care network up and running and functional and really getting to the point that they wanted it to be at. And so one of the things they had to do was really say, okay, what do we want to focus on? What are our main goals? And so they wanted to participate in the bundle payments for care improvements in round 1. And as they did that, they figured out that they didn't really have any data. What they did have was really poor data, and they didn't feel like they were going to be successful if they participated in that program. So they really laid out a timeline and said, okay, let's work together. Let's figure out what is it that we need to do, what sort of data do we need, how do we gather that, what are going to be our critical components to success, and let's lay out our framework for the next couple of years to really get us there. And as they went through this program, I mean, it took them a couple of years to really get where they needed to be. Part of it is it was so important for them to educate their board and management early and often in the process. The boards really needed to be engaged and understand what they were trying to accomplish. If you think about it from a board perspective, these used to be competitors, and now they're working together. And the management team just needed to be on board because there were lots of changes within each organization that needed to take place. The other part was getting all of the staff to work together at all 3 of the entities, whether it was the financial staff or the clinical staff. Everybody needed to figure out how the components were going to work together, what were clinical protocols, how are those going to change, who is going to drive those changes, and really being able to identify all of that as they went through the process. And as they were able to successfully identify and create those protocols and get everything working together, then they were able to reach out to the payers and their referral sources and really establish themselves as that point person or that point of contact, that one entry into the post-acute care space for individuals coming from the hospital. One thing that they did do is, obviously, as you can imagine, we're all busy with our day-to-day jobs, trying to find time for someone or a couple of individuals to really take on an initiative like this can be very time-consuming. So they did hire an executive director to run this post-acute care network and to do the business development. So it was a process for them, and they made a financial commitment to really move this forward as a business working together. And so obviously the clinical processes were going to be really important for them. They started out looking at 9 different protocols. They had a joint clinical committee from all 3 of the entities working together, looking at that bundled payment as a starting point and figuring out how they could reduce readmissions, reduce length of stay, what was that care transition going to look like. So it was a challenge getting everybody working together, but they definitely were able to do so. And the other thing that I want to share through this process is that it is a financial commitment. So we say, show me the money. The first 3 years of the 4 years before they got it up and running were really an uphill battle to get any of the payers or the hospital systems interested. The hospitals at that point, the ACOs were fairly new, so they were very distracted by just doing their own thing and getting their ACOs started. So it was a financial commitment on each of these 3 providers to really participate in this post-acute care network. So what they found were their success factors is, one, they were committed to doing it, and they dedicated the time, money, and resources to do it. Their board and their management and the staff were all on board. They all understood the importance of it, and they were always doing education about the impacts, what needed to be changed within their organizations, and making sure everybody was committed to making those changes. And as I said, financially, all of them were able to set aside reserves to help fund it in the initial stages until they were able to get it successfully kicked off and enter into some bundled payment arrangements with a couple of hospitals. So where are we going now on the horizon? Lots of changes with the administration, and I wish I had a crystal ball because we don't have all the answers. I have not had a chance to read the repeal and replace bill that came out yesterday. So I'm really interested on seeing how that impacts some of these alternative payment models. I don't see them going away. Really tying quality to payment is really, I think, going to stay. Whether they're mandatory or voluntary, I think remains to be seen. So it's figuring out how are you as an organization really going to continue to evolve in a value-based payment world, because we're going to see that continue to move forward. We are seeing providers and payers increasingly partnering and collaborating together, and that's going to continue, helping reduce cost and provide better quality of care. Definitely looking at site-neutral payments. We may or may not see mandatory alternative payment models, but really what CMS is looking at is trying to figure out how to slow healthcare expenditures when we know that the baby boomer population is going to be exploding and increasing those Medicare expenditures. So how do we reduce that on a per beneficiary basis? So again, looking at how do you as an organization prepare, making sure that you understand these different payment models. Don't go it alone, collaborate, figure out how you get involved in different networks. Make sure you understand your clinical pathways, what can you do to improve quality. Make sure you understand how those quality metrics are going to impact your payment in the future. Because like I said earlier, what's being collected today is going to impact your payment in the future. So with that, I know we have about 5 minutes left. I will open it up for questions.
you so much, Deb. At this time, we'll go ahead and move into the question and answer section of today's call. If you have a question, please use the chat feature at the bottom right corner of your screen. It doesn't appear that we have any questions at this time. Is there any last parting wisdom that you would like to provide, Deb?
Thanks, Heather. Like I said, just right there at the end, it's so important to understand what's happening in your organization, especially from a quality and a metrics standpoint. Understand how all of those impact your payments on a go-forward basis. And some of those may seem like small adjustments to your payments. We had the 2% sequestration that hit a couple of years ago. That's still in there. And some of these value-based payment incentives and withholds that may be a 2% here or 1% there based off your quality metrics. They're going to continue to add up. So just really understanding what you can do to maximize that value-based incentive payment that you get back. And be open to partnering with organizations you've never considered partnering with before. It's kind of a new world, and the more you can kind of step outside that box and figure out how to do things differently and provide quality of care and better outcomes, it's going to be an interesting transition, I think.
Great, thanks so much, Deb. We did have one question come in while you were giving some additional thoughts. One of the participants would like you to clarify the difference between hard steering versus soft steering.
Yep. So hard steering is, especially under some of the ACO models in the next Gen ACO, where a beneficiary gets a payment incentive for staying with providers that are in the ACO network. So they still have their choice of provider that they go to, and they don't have to stay in the network, but there is some financial incentive to that. Now, the soft steering, which we've all seen for years within healthcare, is based off quality. If you're a preferred provider with a hospital, where we're seeing some of the hospitals, if you're one of their preferred providers, their pick list or their discharge planners giving information to the patient as they're being discharged, and they're saying you can pick from anybody on this list, but these providers that are green, for example, or at the top of the list, are those providers that we have a preferred provider working relationship with. So that's more of the soft steering. The hard steering is that financial incentive for the beneficiaries.
Great, thanks so much for that clarification, Deb. It does not appear that we have any other questions at this time. So I would like to take this time to thank everyone for joining us during today's webinar. I would also especially like to thank our presenter, Deb, for sharing her expertise, time, and commitment to making this a successful program. Thank you everyone again for your participation, and I hope you have a wonderful afternoon.